It is my pleasure to introduce you to today's speaker, Dr. Brent Boyett. Dr. Boyett received his doctorate in dental medicine from the University of Alabama at Birmingham and his osteopathic, my words getting tangled, medical degree from the University of Health Sciences in Kansas City, Missouri. He completed his residency in family medicine through the University of Mississippi and currently holds a board certification in family medicine and 2 board certifications in addiction medicine. He has been recognized as a distinguished fellow by the American Society of Addiction Medicine. Dr. Brent Boyett is currently working with Bradford Health Services and is dedicated to continued growth in the rapidly evolving medical community and environment of addiction medicine. His primary focus is on addiction treatment and research, and he remains on the cutting edge of technology and training. Please type any questions you have during the presentation into the Q&A box for Dr. Boyett to answer at the end of his presentation. Dr. Boyett, the mic is now yours.
Thank you very much, Wendy. I appreciate that. And good afternoon, everybody. Thank you for joining us. I appreciate you taking a look at buprenology, sort of a word that we've coined to take a focused look at the molecule and the medication and the therapeutic effects of buprenorphine, specifically in its application to the treatment of opioid use disorder. But it's important to recognize that it has other applications as well, which may also provide benefits. So we'll talk a little bit about that. Let's go to the next slide. I have no financial disclosures to disclose. Next slide. So talking just a little bit about the molecule of buprenorphine. And let's just drill down on the specifics of this molecule and how it works on the central nervous system. Buprenorphine is a partial agonist opioid that activates weakly the mu-opioid receptor of the central nervous system. It also antagonizes the kappa opioid receptor. So it fits in that class of agonist-antagonist opioid, and also fits in the class of partial agonist opioid, similar to other partial agonists, antagonists, such as Stadol, Nubane, Talwin, those kinds of medications, but it has some unique properties that differ from these other partial agonists. It has a very strong affinity for the mu-opioid receptor and a very slow dissociation. It has a very long half-life and duration of action, especially when administered through the transmucosal sublingual route. It is technically a semi-synthetic analog of thebaine, which is an opioid alkaloid. And this is the molecule itself. Next slide. So looking back a little bit at the history, treating opioid addiction with an opioid has long been a controversial topic. And we would need to go back really beyond 100 years, but just to look at the situation over the past 100 years, our thinking of opioid treatment has changed. And so if we go back to the last great opioid epidemic, which was at the turn of the century, right after the Civil War, in the late 1800s into the 1900s, when opioids such as morphine and codeine were highly unregulated. There was a huge issue, public health issue in the United States at the turn of the last century, at which people were dying of overdoses and becoming dysfunctional as the result of a habitual use of opioids. There was a certain period of time when you could literally buy heroin from the Sears and Roebuck catalog. And in many cases, because medical societies were so highly unregulated at the turn of the last century, generally speaking, doctors were governed by their county medical societies throughout the nation. And there was not very much of a standard of care. During those days, you might go to Marion County, Alabama for Dr. Boyett's secret formula for melancholy mood. And I might sell you a bottle of my secret formula that might have morphine sulfate and maybe even a tincture of cocaine added to this. And you know that when you took my secret formula, your mood would improve, your aches and pains would improve, but when you didn't have it, it would become worse and worse and worse. And so that became a commonplace practice during that time. People, the use of these medications were highly unregulated, and it became such a problem that after the turn of the century in 1915, Congress took the unprecedented action of enacting the Harrison's Anti-Narcotics Act. It was literally a tax law that put prohibition on the use of opioids for non-medical, non-legitimate treatment. And that had to be defined. And that was later defined in around 1919 through a precedented federal court case in a regional federal court in Memphis, Tennessee, where it was called Webb versus the United States, where a pharmacist was convicted of a violation of the Harrison's Anti-Narcotics Act for providing morphine to opioid dependent and addicted patients and so forth. And this began a large scale nationwide process of indicting physicians and pharmacists and others for the distribution of opioids for non-medical purposes. And the treatment of opioid dependence was considered to be a non-medical purpose. And that during that era, opioid addiction was not really considered a medical condition. It was considered more of a moral condition. And during most of the 20th century, the regulation of opioids was largely relegated to the criminal justice system. And doctors and the public health kind of took a hands-off approach through most of the 20th century. And that was true up until 1970, when President Richard Nixon signed into law the Controlled Substance Act. And during that piece of legislation, massive piece of legislation that actually set up the DEA and also set up what we know as our controlled substance levels, Schedule 2, 3, and 4, and so forth. But there was a carve out in 1970 for an exemption to the Harrison's Anti-Narcotics Act for methadone, for the treatment of opioid dependence and opioid addiction through federally qualified methadone clinics, opioid treatment programs, OTP. And so that was the only exception to the Harrison's Anti-Narcotics Act until later. And we'll talk a little bit about the history of what has transpired since the Controlled Substance Act. But let's talk a little bit about the history of the molecule itself. Buprenorphine, the molecule itself, was actually patented in 1965. Human trials began in 1971, and the maker of the medication, or maker of the molecule that held the patent, Rickett Benkaiser, actually looked at several different partial agonists medications during that time, and they focused their research on buprenorphine specifically for various reasons. So they first launched as a product in the United Kingdom in 1978. And in that time, it was approved for the treatment of moderate to severe pain in an IV formulation known as trade name Buprenex. It was approved for medical use in the treatment for moderate to severe pain in the United States in 1981. So it's important to point out that buprenorphine has been used for decades for the treatment of pain, moderate to severe pain, long before it was actually studied for the treatment of opioid use disorder. The sublingual delivery launched in the United Kingdom in 1982, again, for the treatment of moderate to severe pain. Still no use for opioid use disorder at that time. Next slide. In the 1900s, or in the 1990s, reports began to emerge out of Paris, France, where heroin-dependent patients were regaining function by the use of buprenorphine. So, in the year 2002, U.S. Congress passed the Drug Addiction Treatment Act, also known as Data 2000, that gave the Secretary of Health and Human Services the authority to grant physicians a waiver to prescribe a controlled substance, a Schedule III opioid narcotic, for the treatment of opioid use disorder. Again, this was the second exemption to the Harrison's Anti-Narcotics Act. Methadone through federally qualified opioid treatment programs was the first, and Data 2000 was the second, allowing physicians and qualified prescribers to use buprenorphine for opioid maintenance in opioid use disorder treatment. In 2002, Rickett Benkaiser, who's now in Divior Pharmaceuticals, combined buprenorphine with naloxone as a deterrent for IV administration. So let me back up and just tell you how this occurred. As people with opioid use disorder began to use buprenorphine to establish balance in hedonic tone, pain and pleasure perception, the street, people who use the medication, patients themselves, begin to learn a little trick, and that is this. Out of an 8 milligram sublingual or transmucosal buprenorphine subutex tablet, only about 2 milligrams on average is absorbed sublingually, which means that about 6 milligrams is swallowed. Swallowed buprenorphine is by and large wasted buprenorphine because of the first pass effect of the liver. When the hepatic portal circulation picks up buprenorphine in the gut, it takes it through the liver, and the liver, through a cytochrome P450 pathway, changes buprenorphine into the molecule of norbuprenorphine. Norbuprenorphine does not effectively cross the blood-brain barrier, and so therefore, swallowed buprenorphine is largely good for constipation only the side effects. Norbuprenorphine doesn't cross the blood-brain barrier and never makes it to the brain in any significant amount to do the work that we specifically want it to do. So only the transmucosal delivery bypasses the hepatic portal system, gives the patient a direct line through the blood-brain barrier to do the work at the central nervous system's opioid receptors. But because so much was wasted, what the street began to learn is that they took all of the buprenorphine and injected it through the IV route. Then they could get all 8 milligrams or 16 milligrams streamlining to the brain unimpeded by the hepatic portal system, and they would experience an override of the ceiling effect that is famous for buprenorphine. And so people begin to inject their buprenorphine. So when this happened, researchers began to look into adding naloxone, a complete antagonist opioid, to the preparation of buprenorphine in a 1-to-4 ratio, so that if a patient administers the medication the way it was intended through the transmucosal, through the sublingual route, then the buprenorphine effect would predominate. Naloxone is a very large molecule and is not well absorbed through the transmucosal route, and so therefore is not effectively not effective through the transmucosal delivery system, especially when delivered in a 4-to-1 ratio with buprenorphine. So the idea was that if you took it appropriately transmucosally, it would work as it was intended. However, if a person cheated and administered through a parenteral route, then the naloxone would predominate, and this would actually precipitate withdrawals, and it would not have the rewarding effects that the IV route without the naloxone would have. And so it was added only as a deterrent for that IV administration. It's important to note that the ceiling effect, and we'll talk more about this in a later slide, the ceiling effect of buprenorphine is not caused by the addition of naloxone. Buprenorphine by itself, Subutex, or any monotherapy buprenorphine preparation has the ceiling effect without the naloxone. The naloxone is only there in a 4-to-1 ratio as a deterrent for IV administration. Next slide. Later, new buprenorphine guidelines, and these are very new, allow all providers who have a DEA and are capable and qualified to write Schedule 3 narcotics. They can prescribe buprenorphine to combat opioid use disorder without the 8 hours of training for physicians, or the 24 hours of training for mid-levels, up to 30 patients at any given time. So even if you're not DEA waivered through the data 2000, now qualified controlled substance prescribers can manage up to 30 patients. But however, they do still need an X waiver number. It's just that they don't have to do the 8 hours of the 24-hour complete training. Next slide. I apologize for this, but this is just a little bit blurry, but this just demonstrates the half-life of buprenorphine as compared to other opioids. And also note that, that the transmucosal, buccal, and sublingual routes are longer than the IV administration routes, the duration of action or the half-life of the medication just through that administration. Next slide. So what makes buprenorphine unique? What makes it uniquely qualified for patients to self-administer an opioid narcotic in a home setting under their own supervision? Here are some things that make it unique. First of all, it has a very strong affinity for the mu opioid receptor. And if you compare it to other classes of opioids, antagonist, partial agonist, and full agonist, the affinity, in other words, the battle for the mu receptor is as follows. Antagonist, complete antagonists such as naltrexone and naloxone have a stronger affinity for the mu opioid receptor than partial agonists such as Stadol, Nubane, Talwin, and buprenorphine. Partial agonists have a stronger affinity for the opioid receptor compared to full agonists. And this is a general statement. There are some full agonists that have stronger affinities than others, but generally speaking, these three classes of opioids have a gradient of affinity for the opioid receptor. Antagonists will win the battle over both partial agonists and full agonists, and partial agonists will win the battle over full agonists. So buprenorphine, once it docks with the mu opioid receptor, it produces a blockade effect. So it activates the mu opioid receptor weakly, in a weak fashion, but it also, especially at certain plasma levels, and we'll talk about this, blocks the effects, or at least mitigates the effects of full agonist opioids. So the blockade effect is very important, and also the ceiling effect on mu receptor activation is also very important, and what makes this molecule very valuable as a self-administered treatment for opioid use disorder. Next slide. So this is the dose effect curve, and there's a lot of information in this one particular slide, and there's a couple of things that I would like to talk about here. First of all, let me just explain that on the vertical axis to your left is opioid effect. I think of that as hedonic tone. So think of that as you move up the vertical axis, there is pleasure or euphoria. And as you move down toward the bottom of the vertical axis of the opioid effect, there is dysphoria or pain. So smiley face at the top and a sad face at the bottom of that vertical axis. And then imagine on the horizontal axis that there is dose of the drug, milligrams or whatever, in terms of your weight measurement of the medication. So full agonist medications are dose dependent by and large. As you see, there's kind of a linear effect between dose and effect. The more you move up in dose, the more you move up in pleasure or reward or euphoria, all the way to the point at the very top when a person is so completely content and relaxed and satisfied that they forget to breathe. That's called the lethal dose, and that's when a person dies. and it is on a gradient linear scale. The more you take, the better you feel. On the bottom axis, represented by the triangles, is a complete antagonist. That would be naloxone or naltrexone that blocks the opioid receptor. No matter what dose you give, it doesn't give any reward. It doesn't activate the mu receptor. It does not give any pleasure. However, it does block the effects once it puts a padlock, so to speak, on the mu opioid receptor. It blocks or at least mitigates the effects of other opioids, such as partial agonist and full agonist. So that's an important point. That ceiling effect that occurs with buprenorphine makes it very effective at taking hedonic tone of people with opioid use disorder, which is generally in the area of dysphoria, and putting them back in the middle with a homeostatic balance between pain and pleasure. But because of the ceiling effect, it makes it very difficult for opioid tolerant individuals and opioid tolerant brains to become euphoric, high, dysfunctional on a partial agonist opioid such as buprenorphine. Which leads me to another concept that we need to discuss in this slide, which is precipitated withdrawals. Precipitated withdrawals is the process by which, if a person is induced with buprenorphine after a full agonist opioid, particularly after a long-acting full agonist opioid such as methadone, and increasingly street fentanyl has unpredictable durations of actions too, which makes induction sometimes tricky. Then the prescriber or the physician can actually precipitate withdrawals. So imagine that a person is on methadone, let's say 75 milligrams per day. And they're on that red square axis up above the ceiling effect of the buprenorphine ceiling. And then a person is given buprenorphine. What will happen is that full agonist methadone will be displaced from the mu opioid receptor. And that will create a decrescendo effect or a lowering of hedonic tone rapidly. So a person will experience a dysphoric drop very rapidly, and they will perceive that as a precipitated withdrawals. So that is the reason why it's important to wait for induction until the patient is in moderate to severe withdrawals, generally speaking about a 13 on a CAL score, before the first buprenorphine is given. Otherwise, administering buprenorphine too early can precipitate withdrawals and create a really uncomfortable situation for the patient. So I always tell patients, it's better for you to allow your long-acting opioid or even a short-acting opioid, such as hydrocodone or oxycodone, to allow that to slowly disassociate and let you fall and you experience opioid withdrawals, and then let the buprenorphine take you back up. Because if you're feeling okay, and then you add the buprenorphine onto it, the buprenorphine will displace the full agonist and make the hedonic tone fall, and actually will precipitate the effects of withdrawals, and that will be a very uncomfortable experience for the patient. So it's better to do that over time. Sometimes we are able to bridge that gap with other medications to allow, especially with regards to inductions with methadone and even fentanyl sometimes. Again, street fentanyl is not like pharmaceutical grade fentanyl, and many times has a much longer half-life. Street fentanyl today is generally not pharmaceutical grade fentanyl. It's fentanyl analogs, things like 1,4-dihydroxyfentanyl and other different types of molecules with different side chains that give it a whole variety of different durations of actions and potencies and so forth. So when you think of street fentanyl today, typically what we call heroin, but is usually fentanyl in most areas, don't think of it as being pharmaceutical grade fentanyl. And it may be subject to long withdrawals and may require other treatments to treat the precipitated withdrawals. until a person can be induced with a partial agonist. And the duration of needing to wait for the induction depends on the duration of action of the full agonist opioid that's being delivered. So precipitated withdrawals is a very important concept. Also, the ceiling effect of buprenorphine. Keep in mind that the idea of treating buprenorphine is to create a homeostatic balance between the perception of pain and pleasure. I always say, my definition of an addiction medicine doctor is a doctor who helps patients achieve and maintain a functional balance between their perception of pain and pleasure. And there is a functional balance. We don't function well in complete euphoria, but we don't function well in complete dysphoria either. There is a sweet spot, just like most things in nature. Homeostatic balance is where we are actually on our A game and where we actually function best as human beings. Next slide. So we talked about the importance of the ceiling effect. So the reason that ceiling effect on the last slide is so important is because, and this is exactly why we don't prescribe methadone for opioid use disorder by prescriptions in outpatient settings. Opioid treatment programs generally dose daily. And then once a patient demonstrates stability for a period of time, they do qualify for certain levels of take-homes, certain length of time of take-home methadone. But even then, it's under close supervision. Part of the reason for that is because with full agonist opioids, with the disease of opioid use disorder, the concept of this is in the patient's mind is, or at least the patient's subconscious is, if a little is good, then more is better. And so in many cases, there's the risk of patients would take a month's worth of therapy up in the first 3 days and run the risk of overdose and so forth with full agonists. Because of the ceiling effect of buprenorphine, taking more beyond a certain point really doesn't give that patient the perception of much more reward. It's not a completely flat ceiling effect. Keep in mind, there is a therapeutic window by which you can overdose and die on buprenorphine. But for opioid-tolerant brains, opioid-tolerant patients, it is a very broad therapeutic window or therapeutic index between the effective dose and the lethal dose of buprenorphine. But because it is not buprenorphine, it's not opioids that the patient seeks, it's dopamine. And dopamine can be stimulated in the nucleus accumbens by other means besides opioids. So this is the dopamine channels or the chain in the nucleus accumbens. So if a person is on buprenorphine with a ceiling effect, putting them in that sweet spot of hedonic tone, and then they take a benzodiazepine and stimulate the GABA A receptor, that too will enhance the dopaminergic releasing effects in the nucleus accumbens, enhancing reward. And so that can create a synergistic effect on pleasure and also respiratory depression, because it is through an overdose of euphoria that we develop respiratory depression. So benzodiazepine plus bup, you're overriding the ceiling effect. So too would be psychostimulants such as Adderall, Ritalin, methamphetamine, cocaine, which block the reuptake of dopamine in the nucleus accumbens at the protein transport system. And so if the bup is increasing the amount of buprenorphine in the nucleus accumbens, and then Adderall or the psychostimulant, methamphetamine or others, is blocking the reuptake, again, we're overriding that ceiling effect, bending that curve more toward a linear, creating more of a dose-dependent effect of these medicines, which compels the patients to take a little more, a little more, a little more. And that's the reason why this can become a problem. Keep in mind that the street has researched this long before we have. And the term, when you combine a psychostimulant with an opioid, is called speedballing. And so what you get is the stimulant effect of the stimulant and the sedative effect of the opioid, but both give you a dopaminergic release in the nucleus accumbens, creating a more powerful rush of pleasure to the patient. And so that is the reason why combining other dopamine releasing agents such as benzodiazepines, psychostimulants, Even there's evidence to suggest that even gabapentinoids, such as gabapentin and pregabalin, can also create an additional release of dopamine in the nucleus accumbens, bending that ceiling effect more to a linear effect, making a buprenorphine plus the other dopamine releasing agent more like a full agonist when they are prescribed together. And so that is the reason why providers need to be very, very cautious about combining controlled substances with buprenorphine. Next slide. So here is a cartoon graphic of an opioid. The green figure is actually represents a full agonist opioid, such as heroin, methadone, fentanyl, and the little yellow figures represent buprenorphine, a partial agonist opioid. And the little purple receptor there indicates the actual receptor site, or the mu receptor site. Next slide. So as you can see here, your full agonist, depending on their potency, fentanyl being one of the most potent, provides a more perfect fit down into the mu opioid receptor. And that creates a stronger impulse, a stronger opening of the sodium and potassium channels along the cell membrane of the neuron, creating a much more potent action potential into the nucleus accumbens through the ventral tegmentum area, releasing a flood of dopamine into that, creating a set perception of pleasure. Next slide. This slide demonstrates that buprenorphine is not a perfect fit. It's a poorly fitting opioid at the mu receptor site. And it activates the mu opioid receptor, but it does it very weakly. And it also does it in such a way that there's a ceiling effect beyond a certain point, beginning around 16 milligrams of buprenorphine delivered through a transmucosal delivery, up to about 24. It kind of just levels off, and taking more doesn't really give that much more reward or benefit. Next slide. Also, this illustrates that once buprenorphine has gained access to the mu opioid receptor, it literally blocks or at least mitigates the effects of the full agonist opioid. Keep in mind that these things, when they're in the receptor, they're kind of bouncing around in there. It's the movement, releasing and grabbing and releasing and grabbing, the molecule bouncing inside the mu opioid receptor that creates the action potentials that are being released constantly. If you just completely stimulate the receptor, then the sodium potassium channels would just depolarize and you have a depolarized neuron. So they're constantly, the molecule is constantly bouncing around inside the mu receptor, creating the flood of sodium and potassium, creating these impulses of action potential down the neuron into the nucleus accumbens. Next slide. So this is sort of the effect. Buprenorphine activates the opioid receptor, and it also blocks the opioid receptor. Activating the opioid receptor actually helps to control cravings, so people are not in physical withdrawals, and it also, due to as evidenced by VAS craving scores, patients just don't crave the opioids as much. Now, keep in mind, triggers and influences, external influences, still do affect opioid craving. If people are using opioids around you, then even though your mu opioid receptors may be occupied with buprenorphine, there may still be some craving. But it protects you on the back end by blocking, or at least mitigating, the full agonist effect if a person did relapse. So it's less rewarding. Next slide. This is just a cartoon of the synapse in the nucleus accumbens itself. And so just bear in mind that upstream from this presynaptic neuron is a mu opioid receptor that creates an action potential that runs down that neuron, and at the end of that neuron causes the release of dopamine through the Golgi apparatus at the end of that neuron, that drops drips of dopamine into that synapse, which float across to the postsynaptic neuron, activate the dopamine receptor, creating another action potential that we perceive as pleasure, contentment, satisfaction, so forth, euphoria. Next slide. So here's the ventral tegmentum area enlarged. Inside the ventral tegmentum area is the nucleus accumbens, but you can see that the way this was intended to work is that we actually, our bodies, our brains do produce natural opiates called beta endorphin and other types of natural opioids that are released during moments of perceived pro-survival circumstances that dock with our mu opioid receptor, causing the release of dopamine into that nucleus accumbens synapse, activating those dopaminergic receptors on the postsynaptic side and creating an action potential that we perceive as good, pleasure, euphoria, satisfaction, and contentment. Next slide. So how does this affect behavior? Well, we all have this Dr. Jekyll, Mr. Hyde thing going on inside our brains. We are all kind of two beings in one. And anatomically speaking, in many cases with regards to behavior, this is the prefrontal cortex versus the mesolimbic cortex or the ventral tegmentum area. So prefrontal cortex versus mesolimbic cortex, or future brain versus the now brain. Keep in mind that the prefrontal cortex is uniquely human. Apes and primates have a small prefrontal cortex, but human beings have evolved a very highly developed prefrontal cortex that is able to perceive consequences into the future. It is the part of the brain that is responsible for concepts like delayed gratification, which is I'll go to medical school for so many years, even though I don't really like it, for the reward of a better career at the end of that. Or I'll go to work all week long, even though I'd rather be fishing, for the reward of a paycheck on Friday. You can't get lower life forms. You can't get a dog to do a trick all week long for a treat on Friday because their prefrontal cortex can't project that far into the future. And so it is the prefrontal cortex that makes us understand concepts such as delayed gratification and consequences. These things would say, it might be nice to, steal from the boss at work, but the consequences of that would not be worth the pleasure. Even if it was nothing more than the guilt of the action, it wouldn't be worth it. So I won't do that. That's a prefrontal cortex function. It considers the future in its decision making. But we all have inside our circuitry the primitive brain, the VTA, the mesolimbic cortex. Some people call it the lizard brain. And that only is concerned with now. If you ever talk to a lizard about their future, they'll just look at you. They don't understand the future. They just right now want to eat a bug, right now want to procreate. So it is concerned with the now. And nestled between the future brain, the prefrontal cortex, and the ventral tegmentum area, or the mesolimbic cortex, is the nucleus accumbens that receives input from the prefrontal cortex and input from the VTA and listens to both, and based upon which one sends it the strongest signal, will send marching orders out through the substantia nigra into the cerebral hemispheres that says, get up and pick up the phone and call the dope dealer, or get your mind on something else and don't do it. So that's how this works. So the nucleus accumbens is listening to the angel on one shoulder and the devil on the other. Now, keep in mind, if your house is on fire and or your car is burning and you need to get out, then the VTA becomes the angel, because you don't need to think about the future, you need to act now. So it depends on the circumstances which has the pro-survival input. The problem with addiction in all of its forms, is that the VTA, the mesolimbic cortex, becomes damaged to the degree that that patient is developing a chronic baseline of dysphoria, that the needle is constantly moving based on circumstances. But even during a person who has developed chronic dysphoria's best times, they are as uncomfortable as everybody else's worst times. They've developed chronic dysphoria chronic dopamine resistance in the same way that a type 2 diabetic develops insulin resistance. And so when the hedonic tone needle is pushed into dysphoria, the ventral tegmentum area, the mesolimbic cortex impulse will override the future brain or of the prefrontal cortex, creating, right now, I've got to get a fix of heroin. In other words, it's kind of like, if you were to stick your hand on a stove and the stove began to burn the flesh off your hand, even though that somebody bet you $1,000 that you couldn't leave it on there for 60 seconds, as that flesh began to burn off of your hand, your VTA, your mesolimbic cortex, your pain perception would be so intense that your now brain would override your future brain and you wouldn't care about $1,000 later. You got to get your hand off that fire. That's the way that withdrawals feel to opioid dependent patients, is it feels so urgent. It's like my hand is on the fire. Right now, I've got to get my hand off this fire and I'll worry about the future later. I'll make up for it somehow. So this is that tale of two brains. It's the Dr. Jekyll, Mr. Hyde. And when the needle, keep in mind, the VTA is what houses our perception of dysphoria and euphoria. When the needle is here, the impulse from the VTA overpowers the impulse from the prefrontal cortex, creating the patient, the tendency for patients to relapse and to continue to use the drugs, to do the one thing that they know that will get their hand out of the fire, at least for a while. Next slide. So this is the whole concept of hedonic tone. I do want to cover a couple of other concepts, so let me just go past this one. Next slide. So buprenorphine therapy. Some of the, back in the early days when we started first using buprenorphine, I think we began to take a lot of the philosophies from the pain management mindset, which is start low and go slow and give the medicine for the shortest duration possible. And in many cases, it was just used for a very short period of time, maybe just detox and then discharge, discounting the fact that addiction is a chronic disease. And it would be tantamount to just giving a person, insulin to get their blood pressure in a normal range and proclaiming that you've cured their diabetes and just say, don't eat sugar anymore and you'll be fine, and discharging that patient. That would be ridiculous. And because diabetes is a chronic disease, hypertension is a chronic disease, and opioid use disorder is a chronic disease, detox does not equal addiction cure any more than getting a person's blood pressure in a normal range means you've cured their hypertension. So long we have asked, what is the optimal dose and duration of buprenorphine therapy in the treatment of opioid use disorder? Well, Dr. Mark Greenwald addressed the dose situation in his drug liking studies, and also the duration has been addressed in a recent trial called the Recover study using Sublocade. So let me briefly run over these different trials so that you can kind of see where I'm coming from. Next slide, please. So let's skip this slide. Next slide, please. So in the drug liking studies, Dr. Mark Greenwald at Wayne State University took heroin-dependent patients, these are heroin-addicted patients, into a study, and he gave them hydromorphone, a dose of hydromorphone, and then waited about 8 hours, and then he gave a dose of buprenorphine, a small dose of buprenorphine. Then he waited another 8 hours, and then he drew a plasma concentration level of buprenorphine, and then he gave the patient a choice. Would you like another dose of hydromorphone, or would you like a monetary reward? I don't know exactly what it was, $50 or something like that, $25. Well, if you're opioid dependent, most of the time you're going to pick the drug. Give me the drug. I need another shot of hydromorphone. So he did that. Then he would follow that later with an escalating dose of buprenorphine, wait a period of time, draw another plasma concentration of buprenorphine, and then sometime later, give the patient a choice. Would you like another dose of hydromorphone, or would you like a monetary reward, a $50 something like that. What he noticed is he did that serially over time, that once the patient's plasma concentration of buprenorphine reached a concentration of about 2 nanograms per milliliter, the patients began to choose the money over the drug, suggesting that at that point, that it was creating a satiety effect on hedonic tone, and also probably blocking the effects of hydromorphone. So in functional PET scan, rather functional MRI scans, they also noted, and they were taking functional MRI images of this as well. They noticed that around 2 to 4 nanograms per milliliter of plasma concentration of buprenorphine, that greater than 70% of the mu receptors were occupied. They did it by using tracers that show occupancy of the mu receptors, creating a blockade effect. And that is one of the important things, is the blockade effect and creating a society. So it may not be that the lower dose, the better. It may be more in terms of behavioral extinction. If what we're trying to do is to treat a behavior, it may be more like antibiotics. It may be that we need to get the plasma concentrations up to an adequate level for a sustained period of time to eliminate that behavior, or in the case of antibiotics, to eliminate that bacterial pathogen. We all know that the worst thing to do with antibiotics is to create a sub-therapeutic plasma concentration. That only creates resistance of the bacteria. So if you pull that gun, if you ever pull the gun of antibiotics, you want to get the plasma concentrations up for a proper plasma concentration and the appropriate duration to eradicate the pathogen. It may be that with buprenorphine, we need to get the plasma concentrations of buprenorphine up for an adequate concentration and an adequate duration to eradicate the pathogen, which is the self-destructive behavior. Next slide. So this is kind of how the plasma concentrations equate. And this, I don't have a 16 milligram, but you can see here that for transmucosal buprenorphine at 12 milligrams per day, that immediately in about an hour following the administration of a 12 milligram dose, the plasma concentration of buprenorphine gets up to about 5.35, which is above that 2 nanogram threshold that we talked about. But its average, as the 24-hour cycle goes on, its average falls down to 1.71, and right before the next dose, 24 hours later, the plasma concentrations of buprenorphine fall to a subtherapeutic level of 0.81, well below that 2 nanogram per milliliter threshold that extinguishes cravings and drug liking. As you can see, even for 24 milligrams of transmucosal buprenorphine, right after the dose of a 24 milligram buprenorphine administration through a transmucosal route, the plasma concentrations get up to about 8.27, but the average is about 2.91. But even with maximum dose buprenorphine on a once daily transmucosal dosing schedule, that plasma concentration will fall to subtherapeutic effects at the level of 1.54 nanograms per milliliter plasma concentration of buprenorphine, potentially leaving that patient vulnerable to relapse during that time. So next slide. The RECOVER trial actually looked using Sublocade and asked the question, one of the questions that it answered was, what is the appropriate duration to treat opioid use disorder with buprenorphine through the delivery of Sublocade, which is a once monthly injection. And by and large, I'll just summarize this very quickly for the sake of time. What the study showed that the longer the patient was on the therapy, the better they did after the therapy was discontinued. Now that was true up till 18 months. The study cut off at 18 months. So we don't know if you go beyond 18 months with buprenorphine therapy, if it continues to, if people continue to do better following the discontinuation or not. We would have to have studies. But here is my take on this. How do you know when it's time to start to taper a patient off of buprenorphine? I let the patient work with me in a collaborative effort on that. And I don't force them, generally speaking. I allow them to tell me when they're ready to reduce their dose. And typically speaking, reductions in buprenorphine therapy that are successfully tapered to a period of abstinence requires months to years. And most of the time, it's more like years. Patients will sometimes taper down to lower doses, but they will be on lower doses for years. And there are many patients that may be on buprenorphine long-term, just like they would be on long-term insulin or high blood pressure medicine to control the cravings, and that is okay too. So these studies actually looked at the follow-up after the discontinuation of the last Sublocade injection by self-report of drug use and also urine drug screens for up to a year following the last, for over a year following the last injection. So I think that's it. Next slide. Yeah, that's it. So let me open the door for questions.
Okay. Hi, I'm Wendy Hogue with Project Freedom. So the first question is, if you have a patient on buprenorphine and they need an extraction, what can you or should you do prescribe for them for post-op pain?
Yeah. Well, one of the things is this. Back, if you look at the old TIPS 40 guidelines back years ago when buprenorphine was first being used for opioid use disorder, it would say discontinue the buprenorphine for 3 days and then put them on a full agonist and so on and so forth. That has generally fallen out of favor. And let me tell you why. The morphine milligram equivalents of buprenorphine in the treatment of opioid use disorder is so high, 16 milligrams, 8 milligrams, has really high morphine milligram equivalents. And it's not a linear effect, so it's not a direct correlation. But that is so high. If you discontinue buprenorphine and just put a person on a regular oxycodone or hydrocodone, you've literally created an opioid debt. You've backed up. You've actually increased their dysphoric perception. So generally speaking, what we say is this, or this is my approach, I guess I should say, and CSAM also came out with some guidelines on this. If you can, continue the buprenorphine. If anything, increase the buprenorphine dose in the post-operative period or in the acute pain period, and also increase the frequency. So maybe rather than once a day, you would do a 3 times a day administered dose and maybe a slight increase in the buprenorphine therapy. Keep in mind, buprenorphine was FDA approved and used over most of the world for the treatment of moderate to severe pain, and is a very, very effective analgesic pain medication. Also, you can sometimes get a synergistic effect on pain control by combining an opioid, such as buprenorphine, plus a non-steroidal anti-inflammatory, such as ketorolac or naproxen or ibuprofen. So the combination of non-steroidal plus buprenorphine is very commonly adequate. And I have done total joint replacements. I've done wisdom tooth extractions. I've done a whole host of acute, broken bones, a whole host of acute pain syndromes, and never stopped that OUD patient from their buprenorphine dose. Sometimes we would increase the dose, sometimes we'd increase the frequency. Many times we would add either acetaminophen or NSAIDs onto it, and it provides very adequate pain control. If you have any questions about that, feel free to call me. I'll give you my phone number. It's 205-412-2454, and I'll be happy to discuss cases with you.
Okay, a follow-up question to that is, can a provider see on the PDMP if a patient they are treating is on buprenorphine?
Yes.
Okay.
Buprenorphine does show up on the PDMP. However, methadone administered through opioid treatment programs, through federally qualified opioid treatment programs, methadone does not show up on the PDMP. So if a person is going to a methadone clinic for opioid use disorder treatment, that does not show up in the Alabama State PDMP. Methadone for pain that is filled through the pharmacy, it does show up, and buprenorphine does show up. Now, one exception to that is Sublocade. Sublocade administered through the office does not show up on the PDMP. So in that case, it would not.
Okay, so another question is, when can a patient stop Sublocade?
When can they stop Sublocade? Well, that's a discussion that needs to be had with the patient. I generally like for those patients to be on the Sublocade for about an 18-month period. Now, there are exceptions to that and reasons why a person might not. But because the recover data showed that up until 18 months, the longer you stay on it, the better you do when you discontinue it. I use that as sort of a guideline. Now, beyond 18 months is perfectly fine. There's no mandate to stop it after 18 months. However, I generally think that most patients and providers don't treat buprenorphine with an adequate duration. And I think that an appropriate long-term duration in this conversation you really need to have with that patient. And even when you discontinue the Sublocade injections, I think you still need to maintain a relationship with that patient, because as those plasma concentrations slowly fall, it is not uncommon for relapse to occur. And keep in mind that addiction is not a substance-specific disease, so a patient may relapse to another substance, such as alcohol or methamphetamine or another dopamine-releasing agent. So they still require surveillance even after buprenorphine has discontinued and even after Sublocade injections have stopped.
So we have one last question that I'm going to ask you really quickly because it's anonymous and I can't have you answer it later. It says, in thinking hypothetically about patients, I could see some people continuing to take more and more of the substance in an attempt to feel the effects, not understanding that no matter how much they take, they will not be able to feel the reward or effects. In that event, how does their body not physically overdose from ingesting a large physical amount of substance in an attempt to feel the effects?
Well, you can. Let me be clear. There is a lethal dose of buprenorphine, and it does cause death through respiratory depression. Although that lethal dose is very, very high in opioid tolerant patients that we're dealing with opioid use disorder. Let me say this, and I'm a big advocate for this. There is much more to the treatment of opioid use disorder than just simply prescribing Suboxone. And so that is really should be the take home message. You're absolutely right that Suboxone is abused. It is diverted. There are all sorts of ways that prescribing buprenorphine can go wrong and be detrimental to that patient. So for that reason, close surveillance in a provider who is set up for monitoring drug tests and monitoring random film and wrapper counts, set up for monitoring the PDMP is absolutely essential for quality addiction treatment. If it was just about the buprenorphine, we would just put Suboxone in a vending machine and you could just put your money in and get the medicine. There's a lot more to this than just prescribing the buprenorphine.
Thank you all for participating in today's webinar. To register for future webinars, click on the link in the chat box. We hope to see each of you in the upcoming webinars. Thank you again, Dr. Boyett, for your presentation and time.
Thank you.